So I've talked about the small intestinal neoplasms, the midgut carcinoid tumours. And the reason why the term midgut has perhaps still persisted is because the same class of neuroendocrine tumour can spread not only involving the appendix, which is quite common. The appendix neuroendocrine tumours are very often very localised, and if they're less than 2 centimetres, often nothing more than appendicectomy is required. If the tumour is located at the base of the appendix, where it joins the cecum, the beginning of the large bowel, then sometimes further surgery called a right hemicolectomy is required. If the tumour is more than 2 centimetres in size and shows signs of growth into the local blood vessels and nerves in that area, then again surgery may be required. But usually for most appendix neuroendocrine neoplasms, they're very small, less than 1 centimetre, and often nothing else needs to be done, and often no further follow-up is required in that scenario. And also you would want to make sure that the proliferation index on the pathology has been looked at to ensure that it's a low-grade tumour, which it usually is in over 90% of cases. The terminology midgut neuroendocrine tumours, though, spills over a little bit into the large intestine as well. The first part of the large intestine is still considered part of the midgut from when it was derived, what's called embryologically, from the birth tube that makes the intestine. And those patients with neuroendocrine neoplasms in the first part of the colon, called the ascending colon, and the cecum, can have neuroendocrine neoplasms associated with carcinoid syndrome, similar to the ileal, the distal small intestinal neoplasms. Surgery would be the first line of call, and then the patients, if they've got residual disease, would often go on to the somatostatin analogues, octreotide LAR or lanreotide autogel, and if there was progressive disease beyond that, which was inoperable, Lutathera, the lutetium-177 dotaoctreotate. For the other remaining part of the intestine, the rest of the colon, I'm going to talk about the rectum separately, but neuroendocrine neoplasms in the colon are really quite rare. They have a tendency to be more aggressive neoplasms. So in that scenario, surgery is the first line treatment. But if there is residual tumour, then you might be trying the somatostatin analogues, octreotide or lanreotide is first line. But if the tumour is growing beyond that and has spread, then lutetium-177 octreotate therapy would often be appropriate treatment. Rarely for the very aggressive colonic neuroendocrine neoplasms, chemotherapy, but that would be very rare.